So I'd like to thank the organizers for inviting me to talk with you about aging patients, immune activation in elderly people living with HIV. Here are my disclosures. So to set the stage, we know that the life expectancy gap in people with HIV is narrowing compared to the general population. These are data from the Kaiser group in the United States, showing that the gap in life expectancy has now narrowed to about 9 years in the general population. And that gap narrows even further in people who started ART at a very high CD4 count. But there's still a comorbidity gap that still lags, even in people with high CD4 count nadirs. And so people with HIV are getting things like chronic heart disease, liver disease, lung disease, cancer, on average about 15 years earlier than people without HIV. And while that gap narrows to about 10 years in people with high CD4 nadirs, it's still a substantial gap that persists. So aging complications are a real problem. The life expectancy gap is further reduced by having a low CD4 nadir, so starting ART at advanced disease stages. And this is important because the vast majority of people globally with HIV started ART at a low CD4 count. And so there's about a 20-year reduction in life expectancy in people who started ART at a CD4 less than 350 compared to those that started above 350 in green. And so we're going to be dealing with these issues for a very long time. What's more, mortality is even higher in individuals who have poor CD4 recovery during antiretroviral therapy. So it's not just starting at a low CD4 count, but it's also remaining at a low CD4 count that's really important. In very large cohort studies like the ART-CC and Cohere international collaborations, you see that about 15% of people who start ART at a low CD4 count will remain at a very low CD4 count, less than 200, even after 3 years of viral suppression. And that group has substantially higher mortality than other groups, 2.5% per year, which is really extraordinary. And over a decade, that amounts to about 25% mortality in this group. And so these are folks that are at particularly increased risk for morbidity and mortality. And interestingly, a lot of this is most of it is really non-AIDS causes of death. An almost identical distribution of causes of death in this group compared to people who have much higher CD4 counts during ART. And what are some of those morbidities? I've mentioned a few already, but cardiovascular disease, non-AIDS cancers, osteoporosis, COPD, liver disease, and on down the list. Many aging-related complications are increased in the context of treated HIV infection. Even frailty, a syndrome of morbidity and impaired functional status that we normally only think about in very elderly geriatric populations, we're seeing in younger people with HIV, particularly those who started ART at advanced disease stages. And so why is all this happening? Well, we think that while HIV medicines may contribute to some pathways of disease risk, modern ART regimens are generally quite safe and associated with far fewer toxicities than the older regimens. And it's also true that lifestyle factors that are enriched in people with HIV, like smoking, like drug use, may contribute to both persistent risk for age-associated morbidity and sometimes the inflammatory state itself. But HIV itself contributes to this persistent inflammatory state that's an independent driver of many of these disease risks. And you can get a picture of this from the Insight Group's clinical trials, the SMART, Esprit, and SILCAT studies, where they measured just at a single time point, IL-6 and D dimer, a coagulation marker and an inflammatory marker at baseline in people in the control arms of these trials who just remained on a suppressive ART regimen for up to a decade. And you can see that people in the top two quartiles had a substantially higher risk of morbidity and mortality than those in the lowest two quartiles. So our field's goal is really to move the people with the high levels of inflammation down here into those in the lower quartiles. And you see it's a very similar pattern even in people in the START trial who started ART at a very high CD4 count. You see that those with more inflammation still have higher event rates, even though the absolute event rate is much lower in people who start ART earlier. The relationship between inflammation and events is almost exactly the same. And a whole host of studies that we and others have published over the years have linked the inflammatory state to many different chronic disease endpoints associated with the aging process in treated HIV. And what's more, this is not necessarily equally distributed among all people with HIV. One of the factors that does seem to contribute to the inflammatory state in treated HIV is natal sex. Women are known to have more inflammation than men in the setting of treated HIV. And this is a recent study from our own group in the CNIX network where we profiled a whole host of inflammatory markers that predict disease among ART-suppressed individuals. There's nearly 1,000 people contributed to this analysis. If you break it down by natal sex, women had much higher levels of inflammation than men across almost every single analyte that we looked at. This difference was even greater after menopause. And so after the menopausal transition, inflammation increases even further in women with HIV. Lastly, inflammation appeared to predict mortality and stroke more strongly among women than in men, suggesting that this increase in inflammation may actually have important health consequences. So what can we do to reduce inflammation or mitigate its effects right now? We know that earlier ART initiation helps. In data from the START trial presented by Jason Baker a few years ago, showed that the immediate ART arm achieved an inflammatory set point that was substantially lower than people who were randomized to somewhat deferred antiretroviral therapy in that trial. And so earlier ART, getting people on ART as soon as possible after HIV diagnosis will help reduce inflammatory consequences down the line. The other thing is that better ART adherence also makes a difference. So even in people who have an undetectable viral load clinically, there's often variation in adherence levels. And Jose Castillo-Mancia in Denver has shown in a variety of studies now that compared to people with perfect adherence, if you have somewhat less than perfect adherence, you do have higher levels of inflammation, presumably because small amounts of HIV replication are able to occur, driving inflammation. So encouraging better adherence helps. Moderate exercise has been shown to reduce inflammation, and we know from a host of studies in elderly populations that they prevent disease and improve health in a variety of different contexts. So exercise is good. Stopping smoking and alcohol use can also improve the inflammatory state and disease risk for chronic aging related complications. And treating modifiable risk factors like high blood pressure or hypertension and high cholesterol also make a difference. And so I've attached a couple of references here to support some of those strategies. The other thing we need to think about in our older people with HIV is using a holistic and integrated approach to care in the clinic. At my own clinic in San Francisco, we have a geriatrician, Meredith Green, pictured here on the right, who's really adopted an integrative geriatrics approach to care for a lot of our older patients, focusing on functional status, improved care coordination, integrating consultants, pulmonary, cardiac, psychiatry consultants in the clinic so there's better communication, getting geriatrics and pharmacy evaluations to minimize polypharmacy and drug-drug interactions, and facilitating access to care services in the community, as well as peer support groups to combat social isolation, which is all too common in older people with HIV. So I think a lot of these concepts will be increasingly important as the population of people with HIV is getting older globally. Now, what about other future interventions that we might have access to? So if we start thinking to get at that, we need to think about what's driving inflammation in treated HIV. I alluded to the fact that HIV persists in reservoirs in the body, and while our drugs block new rounds of replication, it continues to leach out from infected cells and tissues and potentially driving inflammatory responses. And so we and others have shown that that's an important contributor. Microbial translocation or a leaky gut barrier is another potential contributor to an inflammation that doesn't seem to get better or completely go away with the antiretroviral therapy. And other co-infections like CMV get worse as a consequence of HIV, even without causing any frank symptoms, may contribute to inflammation in the body, driving disease. And we have been leading a number of studies on that. Here's some recent breakthroughs and interventions to combat microbial translocation. These are data presented by Janet Lowe at Croy earlier this year. She used a GLP-2 agonist teduglutide, which improves gut barrier function. And she showed that this intervention decreased arterial inflammation by FDG PET imaging and also systemic T cell activation. Now, there were lots of tolerability issues, gastrointestinal bloating, for example, that limit the utility of this in the clinic right now, but this was the first proof of concept study showing that restoring gut barrier function might actually reduce immune activation. So this is an important first step moving in the right direction. Our own group has shown that treating asymptomatic CMV infection, particularly in people with poor CD4 recovery, may reduce multiple pathways of immune activation that tend to predict vascular disease and metabolic complications in HIV. And we've just recently started a large clinical trial of the very specific CMV drug, letermovir, that'll be given for 48 weeks in people with treated HIV. And that's just open to enrollment in the ACTG just in the last month. And lastly, we know that statins decrease immune activation and aortic plaque in treated HIV infection. Data from Grace McComsey's group and Nick Funderburg in Cleveland show that rosuvastatin reduced the microbial translocation and monocyte activation marker soluble CD14. And they also showed plaque, and then Janet Lowe's group showed plaque regression with atorvastatin in a trial conducted in Boston. And now there's a large clinical endpoint trial called Reprieve, which enrolled over 7,000 people with HIV on ART to determine whether there's a clinical benefit of statins on reducing heart disease complications and also other non-AIDS events. And so we hope to get results from that trial in the coming years. And then lastly, I'll just mention that something that I always get asked, do you measure inflammation clinically? And so in my own clinic, I actually don't measure these inflammatory markers. They're just for research for the time being. And the primary reason is that we don't yet have proven interventions that both reduce inflammation and morbidity and mortality. So we need studies like Reprieve and others to show that there's a clinical benefit of these interventions. Otherwise, we won't have any interventions to apply if we happen to measure high inflammation in our patients in the clinic. It's also the case that many of the inflammatory markers fluctuate a lot within individuals and that clinically validated cutoffs are not really well defined yet. But all of that may change in the future as we get new interventions and better assays to risk stratify patients. But for the time being, this is where we stand. So to conclude, HIV increases the risk of age-related multimorbidity. Inflammation persists in many people with HIV despite ART and predicts that multimorbidity and mortality. We think that HIV persistence, microbial translocation, and CMV all likely play a role in this process. Earlier ART initiation and better adherence likely decrease the inflammatory set point and reduce multimorbidity. And in the meantime, addressing modifiable risk factors like smoking, diet, exercise, et cetera, will be really important. And using an integrative geriatric approach to care can be beneficial for older patients with HIV. And lastly, the future of anti-inflammatory therapies. Statins show a lot of promise, but we're waiting on the clinical endpoints in the REPRIEVE trial to inform our practice. And there's ongoing research to identify potential future interventional targets, both in microbial translocation, as with the GLP-2 agonist I shared with you, and then also, as I mentioned, CMV. So thank you very much for your attention and have a wonderful conference.